Hi, everybody. Welcome to week 4, cultural safety. Um, I am just going to use this introductory video to talk a little bit about some of the background behind cultural safety, not too much, but mostly just to introduce some of the readings, why we've chosen them, and why I've asked for you to read them in the order that they've come. I plugged culture into the beginning of this PowerPoint presentation, and this is the picture that it came up for me. So I thought it was kind of interesting just to start this, that when you say the word culture, just think about some of the things that it conjures up for people, if it's places or spaces, imagery, and so according to PowerPoint, this was one of them. Okay. So first, I just wanted to introduce here, we're going to sort of build a bit of a toolkit of cultural safety principles and elements, but unpack it a little bit about where these might come from and how they're different in different settings. So the goal of cultural safety ultimately is to improve health. And as we've been discussing, this is the health as determined by individuals. So central to cultural safety is understanding that it's defined and evaluated by the person or persons receiving care. It's an outcome of service, not a strategy. Now, cultural safety is rooted in, or it was rooted in, a response to culturally unsafe care that was made evident by a group of Maori nursing students in the late 80s. And their push for cultural safety was a response to the colonial narrative through which care was being delivered. And so care that's culturally safe recognizes the historical, political, social, and economic contexts that shape people's health and their experiences with healthcare providers. And so much of what we're going to review this week involves situating ourselves as those providers in some form or another, and understanding where we might be within broader social structures that direct many of the healthcare delivery frameworks. And so, as I said, I purposely ordered these readings to step us through this week. And so that we'll begin by being a bit more reflexive in what we bring to these conversations. Then we'll move to how experiences of unsafe care might impact accessing services and overall the quality of life that people experience. Moving then to how culturally safe care addresses holistic health at multiple dimensions: physical, emotional, spiritual, mental, and how culturally safe care has the ability to address structural inequities that create some of the health disparities that we do witness. So this particular diagram here, this is something that was put together by Jessica Ball. She's at University of Victoria in the School of Child and Youth Care. And it has these 5 petals: partnerships, personal knowledge, protocols, process, and positive purpose. And these are laid out and defined a little bit more in this slide here. And so I will put a copy of this presentation right onto the course spaces site. And so if you just review these and maybe think a little bit about each of these as you move through the readings, and maybe reflect on them a bit about if you bring these to your care practice. So first thing that we're going to do, or that I've asked you to do, is to watch this YouTube video, What Every Health Researcher Needs to Know About Health Equity. And so to understand cultural safety and what this means and how this can impact clients or healthcare users, we have to understand what we're bringing to the table. And so watching this video, this is done by Dr. Stephanie Nixon. She's a physiotherapist. She's been a HIV social science researcher and activist for over 20 years, and she does community-based research in Canada and sub-Saharan Africa. She's a colleague and a mentor and a really awesome person, and so I hope that you enjoy watching this as much as I have. Now, the purpose of including this talk, as you will discover, is that we're talking about cultural safety as a way to start dismantling structures that cause inequities in healthcare. So because cultural unsafety is generally developed through cultural norms that may have marginalized or privileged certain groups, we may need some grounding in an understanding of where we fit into this. So Dr. Nixon really works to build our capacity in recognizing societal norms for what they are and unsettling our own perceptions of earned and unearned privilege. And she uses this coin metaphor to talk about the many types of unearned advantages or disadvantages that we may encounter in health settings, And you can kind of see this in the background here, that on one side of the coin is privilege, and those are people who maybe have a benefit others don't. They didn't earn it, but they have it just because of who they are and how they were born. And on the flip side of that coin is oppression, which I did not intentionally cover up with, with other coins, but it is oppression is also equally something that wasn't earned, and it is something that some people have because of who they are. And so she talks about many different forms of oppression. And so for our purposes here, we really need to reflect on how cultural unsafety may be exacerbated by a variety of different intersecting factors, different oppressions. And a key piece that Dr. Nixon gets at is to dismantle the structures that create a need for cultural safety in the first place. And to do this, we have to recognize that solutions to how to accomplish this requires the expertise of those who experience these oppressions. They're the experts. And so I'd like you to carry this messaging with you as you critically engage with the other readings. And through this, or because of this, I've asked you to, or I am going to ask you to privately reflect on this. Here's some questions maybe for consideration. And think of some of the points that Dr. Nixon brings up in the context of what you personally might be bringing to our discussions about health and wellness. And it's absolutely your choice if you want to share some of these or draw on your reflection during the discussions. But I do want to say that reflecting on one's own unearned privilege can be challenging for people. And we need to be respectful that we're all in different places of this journey. And so the intention of this exercise isn't to point fingers, blame, or otherwise. And also, it's not to create divisions that can create perceptions of victim or victimhood or vulnerability. And on that note, I did want to mention too something that has stood out to me that Dr. Karen Urbanowski had commented about, and she's spoken a fair bit about this, and the detriment of the label of vulnerability, stressing that people aren't born vulnerable. It's the conditions that they may encounter that create vulnerabilities. And so again, this is when we're talking about these structures of oppression that people are not born, rather are not part of their being. They're things that maybe operate outside of who individuals are. So I'm just asking to keep this in mind as we proceed this week and and go through some of these readings. So the first reading, this is, it's not directly related to cultural safety and care, but I wanted to include this article by Earnshaw and Quinn. And this discusses the impact that stigma around chronic illness can have on accessing healthcare services and in turn affect quality of life. And the picture on this slide is the model that they put together and that they actually were able to test quantitatively. And the paper itself has some interesting bits just about research methods for those of you who are interested. But in this case too, because cultural safety and care is defined by those who are receiving care, I thought that this might be helpful to consider some of the reasoning why people avoid care. So as we begin reflecting on what an environment of culturally safe care can be, this article presents and tests a model that demonstrates what unsafe care can result in. So now the study cohort is a group of primarily female university students, and as we'll talk about with this coin metaphor, this demographic might be perceived to have a high amount of unearned privilege. And so therefore, if internalized, experienced, and anticipated stigma affects this group so strongly, we have to ask ourselves how these measures would be reflected in other populations, those who may experience oppression on the other side of the coin, who historically have had to bear a disproportionate burden on, in this case, chronic diseases. So by extrapolating these sorts of things to marginalized populations, we can explore, we will begin to explore some of these things in the population health arena and the structures that contribute to health inequities. And through this, just start to discuss why some of these things are and how they've come to exist. So next, the article Reclaiming Birth, Health and Community Midwifery in the Inuit Villages of Nunavik, Canada. So back to the flower vase of cultural safety, this article here speaks to perhaps that protocol stem. So really recognizing the knowledge and capacity that's inherent in communities and teachings. The first is, or rather this here, it's a success story for culturally safe services in remote settings, and the return of Inuit Civic midwifery services in Nunavut to counter the evacuation policies that required expectant mothers to travel to southern communities like Montreal to deliver their babies. So this is an interesting article to consider about how this disruption to what may be perceived as a single event has had ripple effects across the community and also the intergenerational life course of all of those people involved. And so this article really discusses the response to culturally unsafe practices of maternal evacuation and the local capacity building to reestablish Inuit Civic midwifery practices in the community. But despite many of the positives that a return to this program offers, as you'll read, there was opposition to the model. But consider the ways that health and quality of life were defined for the community, and the conceptualization of risk, which included social, cultural, and community processes, and ultimately how the tertiary care, the fly out program, really didn't fit that definition or that view. All right, so next we have creating culturally safe creating culturally safe care in hospital settings for people who use illicit drugs. So I've included this short bulletin, which is part of a larger study that's taking place at the University of Victoria. So the article starts to engage specifically with principles of culturally safe environments and the inclusion of patient voices and patient partners as a really critical piece in ensuring that how we create meaning it's really critical in how we create meaning and read through these theoretical principles. And so their project with working with cultural safety within healthcare services for people using drugs is an incredible project that demonstrates that underlying need for compassion and non-judgment in healthcare. And it's a really interesting example of praxis where we're moving theory into action. And it engages us to start thinking about the ways that we can have a model of culturally safe care while we're still working within a very subjective definition of health. And what this shows here on this particular slide are some of the quotes and some of the comments made by some of their community participants. And if you are interested, you can find out more about this project on their website, and you can hear a presentation that was co-led by the participants who talked through some of these themes that came out of this project. Okay, so lastly, this article here, Applying Cultural Safety Beyond Indigenous Contexts, Insights from Health Research with Amish and Low German Mennonites. So I didn't have a fancy picture for this one, but I thought it kind of is like, it is like a big paint splat, because this article really gets to those underlying principles, that theoretical underpinning around power dynamics and how those are exacerbated in different societal structures. And so this article really applies the 5 principles of cultural safety that are presented up front, and it acknowledges the tremendous trails that have been led through advocacy for cultural safety and care for Indigenous peoples. But it still urges us to expand this to other groups that may experience that oppression on the other side of the coin. And it's an interesting article in that it discusses those theoretical underpinnings that come from critical discourse, which ultimately has its roots in power dynamics and inequitable social relationships. So from this perspective, cultural safety has the ability to shift power in the healthcare domains to the recipients of care. So much like what Dr. Nixon discusses about allyship, and consider allyship, that's a verb, it's an action, not a noun, and the push for patient-oriented research that's led by Drs. Pauly and Dr. Urbanowski. This article similarly calls upon us as healthcare providers in one dimension or another to reflect on our position within a power dynamic and what we can do to initiate change. Okay, so that's my spiel about your readings for this week. And so now I will put myself back here on the video, and you can see here, so we've got 3 questions, and they kind of just run across different ways of applying some of these principles of cultural safety, the ones that have been talked about, how to critically apply them to specific scenarios. And this year, a scenario either described in one of the readings, like perhaps one of the communities that's being worked with, or maybe you might find it more relevant to yourself to apply this to a situation that you've been involved in personally. And then integrate what you've been learning here about practicing allyship. And so how you engage in a culturally safe practice that comes from the invitation and the direction of those who you're working with. So our second question here, I did choose all of these geese on purpose because this is about flying in solidarity. So this is kind of a bit situational. So if the need for cultural safety is rooted in factors outside of the control of a care recipient, so that's like those higher level, those macro social structures, legislative frameworks, you know, in the case with Indigenous people, the Indian Act, those sorts of things, those are outside of an individual's control, but it impacts directly their quality of care. What measures can we as health service providers do to unsettle some of those mechanisms within the workplace? And does that always happen in partnership with our community partners and our patient partners? Or are there things that we can do outside of that? And question number 3. So the 5 core principles of cultural safety, you'll see that Dr. Polly and her team, they introduce also some other elements of cultural safety that think about how you can adapt those to different situations outside of just people who are using or have used illicit drugs. But we now have this toolkit here. So think back to week 2 and how we had that back and forth, that discussion around that universality of a health definition. Is that possible? Is that not possible? How does cultural safety remain in the hands of those receiving care? How do you navigate creating policies around cultural safety without removing the voice of the recipient of care, which is, as we've said, the ultimate measure of cultural safety. It's defined by those receiving the care. So how do you navigate that? So anyways, it's gonna be fun. I hope you enjoy the readings this week. They're not too lengthy, and my hope is that this can be as reflexive as it can be critical. And again, just a reminder, please be mindful that everybody is or may not be at different places of recognizing their own privilege and how to situate themselves within practice. And so just be respectful of that as we're going through, and have a really great week.